Welcome to this explainer, everyone. Today, we're diving straight into some seriously high-stakes anatomical mapping of the pelvic sidewall during a pectopexy. For those of you who are postgraduate surgical students gearing up for your upcoming rotations, this is absolutely essential viewing. We're focusing specifically on just how incredibly close our surgical instruments get to major vascular structures when we're operating in this tight space. It's basically a masterclass in spatial survival in the OR. Here is our roadmap for today. First, the pectopexy procedure. Second, mapping the danger zones. Third, external iliac vein proximity. Fourth, corona mortis and beyond. And finally, real-world surgical application. Let's get right into it. Before we actually look at the data, let me ask you a critical, real-world clinical question. When you're deep in the pelvis operating, what's the exact cost of a single centimeter of error? You guys are postgraduate students, you already know that just a millimeter can literally be the difference between a textbook suspension and a catastrophic vascular injury. Keep that razor-thin margin in your head as we go through this. Section 1. Pectopexy procedure, the surgical anchor. Okay, just so we're all starting on the exact same page, let's look at our surgical anchor. We're talking about the pectineal ligament, which you probably remember from gross anatomy labs as Cooper's ligament, right? It's that fibrous connective tissue extension lying right over the iliopectineal line. It originates at the pubic tubercle, where it's at its absolute thickest and strongest, and then it just kind of progressively thins out as it extends laterally toward the iliopubic eminence. This tough ligament right here is the foundation for the whole procedure. Now, the clinical problem this anatomy actually solves is pretty fascinating. In a pectopexy, which we use for pelvic organ prolapse, we use this incredibly strong ligament to suspend a prolapse uterus or a vaginal vault with mesh. You might be wondering, why go with this over a traditional sacrocolpopexy? Well, because the pectineal ligament gives you a distant space away from the intestines, the sigmoid colon, presacral vessels, and the ureter. It essentially buys you a safer surgical field away from those major abdominopelvic organs, drastically lowering your risk of bowel and ureteral injury. But as we're about to see, it introduces a completely different, very real set of risks. Moving on to Section 2, mapping danger zones, prevesical spaces. Take a really good look at this meticulous, complete pelvic dissection from Dr. Poulatolu and her team. This right here is your exact surgical field. To get this specific view, the researchers performed a complete pelvic dissection, accessed the retroperitoneal area, reflected the peritoneal covering the urinary bladder, and just meticulously cleared out all that fatty lymphatic tissue from the retropubic space of Retzius. You can clearly see the pectineal ligament, the external iliac vessels tracking right alongside the psoas major muscle, and way down deep, the obturator nerve in the obturator space. This is the precise terrain you've got to navigate. To actually map out this danger zone, the researchers didn't just guess. They conducted a super-focused investigation. They performed bilateral dissections on 7 fresh frozen female cadavers. Now, the fresh frozen part is absolutely key here because it minimizes the post-mortem tissue shrinkage that can completely throw off your measurements. Their main goal? To measure the exact distance from the midpoint of the pectineal ligament, which is literally the exact spot you place your suture during a pectopexy, to all these adjacent vital structures. Which brings us to Section 3, external iliac vein, the closest neighbor. So let's break down the actual hierarchy of your surgical threats here. Measuring from the midpoint of the left pectineal ligament, they found the mean distance to the obturator canal was about 3.12 centimeters. The corona mortis was sitting at 2.15 centimeters away. But the external iliac vein, it was a dangerously close 1.04 centimeters away. That right there is your closest, most immediate neighbor when you're throwing that suture. I really want you to focus on this exact number, 1.04 centimeters on the left side and roughly 1.25 centimeters on the right. This makes the external iliac vein the absolute closest major anatomic structure to your anchoring suture. Think about that for a second. When you're operating and you're angling your needle to take a bite out of the lateral part of the midpoint of that ligament, you have just over a single centimeter of clearance before you hit a major pelvic vein. That is practically nothing. Let's translate this back to the cadaver lab. See that X? That marks the exact suturing point for the pectopexy, right on the lateral portion of the middle of the pectineal ligament. Now trace that little line labeled A over to the external iliac vein. Visually, that margin is just unbelievably tight. You should honestly have this image seared into your brain for your next rotation. The topography here basically dictates that as you proceed laterally along the ligament, your risk of a gross vessel injury absolutely skyrockets. Section 4. Corona mortis and beyond, secondary hazards. Now, obviously, you also have the corona mortis to worry about. This pubic anastomotic vessel literally translates to the crown of death, which is a pretty dramatic name that definitely highlights some historical surgical fears, and it sits roughly 2.2 to 2.4 centimeters away from your suturing point. On the other hand, the obturator canal, which houses the neurovascular bundle, sits comparatively safely at over 3 centimeters deep within the fatty lymphoid tissue. So while the obturator canal isn't your primary concern during this procedure, the corona mortis is definitely close enough that a clumsy movement could cause some major headaches. To really wrap your head around where these distances originate, we have to look at the ligament's overall dimensions. By measuring the total length of the pectineal ligament, which averages out to 5.9 centimeters on the left and 6.5 centimeters on the right, the researchers gave us a really reliable landmark. They found that the precise midpoint, your target zone, is essentially 2.8 to 3.6 centimeters away from the pubic tubercle. As PG students, finding that pubic tubercle first is your absolute key to orienting yourself in that space and finding that safe midpoint to anchor your mesh. Finally, Section 5, Real-World Application, Navigating the Margin. The authors of this study really don't leave any room for ambiguity here. They explicitly warn that even though Pectopexy is a fantastic, safe alternative to sacrocolpopexy, especially for avoiding bowel and ureter injuries, the sheer terrifying proximity of the external iliac vein demands absolute surgical respect. A major vascular injury in this space can go from bad to life-threatening in seconds. The anatomy simply does not give you a buffer zone to be careless. So here is exactly what you need to take away from this explainer for your very next case in the OR. First, mathematically and tactilely find the midpoint of the pectineal ligament, roughly 3 centimeters out from the pubic tubercle. Second, visualize that razor-thin 1 centimeter boundary between your needle and the external iliac vein. And third, and honestly, this is the most important part, actively and gently retract that vein laterally before your needle driver ever even touches the ligament. Don't just trust your depth perception, mechanically create that space. At the end of the day, anatomy isn't just about memorizing names on a flashcard to pass an exam. It's about spatial survival in the OR. It's about keeping your patient safe when the margins are this incredibly tight. So I'll leave you with this final thought. Armed with this precise, millimeter-accurate data, are you fully prepared to navigate that 1 centimeter margin of error the next time you have a needle driver in your hand? Think about that gap, respect the anatomy, and let this knowledge guide your hands.